Hey, I'm just letting folks roll in for a minute. Got a lot of folks knocking on the Zoom door. Okay, should be starting here in a minute or two. It's Wes. Okay. So, is Leah here? Yes,
I'm here.
Leah.
Yep, just was waiting for you.
Okay. I think we're ready to go ahead and get started.
Fabulous. Hello, all. Welcome to SOCAC's Program and Policy Subcommittee. I'm Leah Tucker, and I co-chair this committee with Ebony Clark, OHA's Behavioral Health Director. This is the July 22nd meeting of Program and Policy Committee, and this meeting is being recorded and will be posted on SOCAC's YouTube channel for easy public access. First, we'll start with roll call for voting members of the subcommittee, review our group agreements for this meeting, and then get an overview of the agenda. Then we'll move into the actual content for today. And I think Ebony is stuck in a meeting and will maybe make it, but maybe not. So in the meantime, I think Anna's gonna do the roll call.
Yep. So, scrolling down, these are our approved members. So I'm gonna just go through this list by twos. We know Ebony isn't here right now, so Leah Tucker, Sonia Little Deer Evans, go ahead and say here if you are in fact.
Here, Elia.
Here.
Thanks, Sonia. Courtney Esparza and Lacey Andreessen. Don't see either of them. Corinne Hale and Selby Stebbins.
I'm here.
And
Corinne.
Selby is still on sabbatical, so it would be shocking if she were here. Nate Latanzio and Sheila Ward.
Here.
Here.
Thank you. Trisha Patterson and Wes Rivers.
Here.
Here.
Chelsea Holcomb and Molly Haynes.
Here.
I don't see Chelsea. Remy Watts and Meg Carey.
Here. Hello.
Hi, Remy.
Hi.
Uh, I know Lydia is excused. Jeremy Buchanan and Jared Hayes.
Jared Hayes here.
Jeremy here, and I also have Shaylis, my designee. I'm going to have to step out for about 10 minutes for a conflict, but I'll be back.
Excellent, thanks. And Shaylis, thanks for. Shaylis and I just left the same last meeting together. We came over here virtually hand in hand. Alex Solis. Oh, no, I skipped people. Debbie Martin and Anna Day.
I'm here.
Got you, Anna. Monique Turner and Alex Solis.
Here for Alex.
And I called someone's name and then they came into the room later. Was it Courtney Esparza? She is now here. Christy
Yeah.
Reese and Brian Detman.
Yep, I'm here.
Hey, Brian. Good to
Hey,
hear you.
good afternoon.
Alicia Riddle. And the rest of you, if you're here and your name wasn't read out, you are a guest, please do feel free to speak up. I do want to give a quick moment for two of our new members, Sheila and Trisha, if they are interested and comfortable to just briefly introduce themselves to the committee. They are the two newest approved members of this, voting members of this committee. So I see Sheila's coming off mute. Sheila, let me take down the presentation and give you a little bit of room on the screen. Do you mind just quickly introducing yourself?
Thank you. Hi, everyone. I'm Sheila Ward. I've been advocating for children for over 30 some years. I have a in-home program myself, and I enjoy doing this work, and I'm glad that I'm here with you. Thank you.
Thanks so much, Sheila. We appreciate you being here. And Trisha.
Hi, everyone. My name is Trish. I got involved with POIC for early prevention and some other services, and have found a heart in trying to advocate and trying to get into some other kind of services as well. So this kind of fell into my lap as an option, and have some highly driven motivators to find some resources and help the community. So really happy to be here. Thank you, guys.
Thanks for being here, Trish. And just for the rest of the committee to be aware, Trish and Sheila are lived experts. They are bringing family voice into this space, and they are connected to a bunch of other family leaders. And so through the SOCAC Family Affinity space, and so they are bringing information from those family leaders into this room, and they are bringing information from this room back to those family leaders so that we're having dialogue. And if you all have questions for them or for us, please do feel free to let them know. Leah Tucker is also a family leader in this space, and they partner together to try to make sure that family voice is centered in these conversations as we move forward. So not sure, Leah, Trish, or Sheila, if there's anything else you would say about that, but I just want to make sure people really understand that very important role you're playing in this space for us. Great. Thanks so much.
Yeah.
Back to you, Miss Tucker.
So we are going to talk some more about the school-based supports. Christy Hudson, SOCAC's transformation manager, is here to continue that conversation that we started last month about school-based services and supports. So Christy, the floor is yours.
All right. Good to see you all. So just kind of picking back up from where we left at the last meeting, if you all recall, there were kind of three topic areas that we spent time talking about. One was related to what we can do to coordinate and expedite access to assessment in a variety of settings, right? Like behavioral health assessments, IDD related assessments, assessments that happen in the education realm for special education, right? That whole thing, what happens there. The second area we talked about was around delivery of services and supports for youth with complex behavioral health needs within the school setting, right? So not so a little bit about special education, but more broadly thinking about the MTSS framework, oh boy, Remy. MTSS, multi-tiered systems and supports. Okay, did it. And exactly what that looks like within the schools. How can we better resource and equip schools and teachers and staff within schools to support students? And then the third bucket was around coordinating services and supports that happen within schools with community-based providers. So young people who, how can we support them in school, and how can we also make sure that those adults, those caregivers in the school setting are also in communication with the providers that youth may be seeing outside of the school setting. You all went into some breakout groups and came back with a list of like 7 ideas that you had come up with and kind of in those breakout spaces. I spent a little bit of time thinking about those topic areas and put together an attachment that I'm going to share. This is also in your calendar appointment if you want to look at it on your own. And it is this PDF document. Looks like this, school-based services. I think it's something impact and feasibility. And let me try and make this a little bit bigger for you. Okay, is that better? Okay. So this is really just like a starting place. This is not comprehensive by any means. So, I'll kind of walk through this. And if there's other things that you want to shout out or other pieces that you think are relevant to each of these areas, like please let us know. Anna and I have also been kind of doing some additional follow-up and thinking about these topics. And we do have a proposal for you all kind of in relation to all of this, but let me kind of like, take a step back and kind of show you how we got here. So the idea of focusing on centralized care coordination and really trying to fix the care coordination system, particularly for multi-system involved youth, came out of two breakout rooms. There's a lot of leverage points here. The early periodic screening or diagnosis, screening, and treatment benefit. Certified community behavioral health clinics are already supposed to be doing this kind of care coordination. Of course, Fidelity Wraparound is a big component here. There's a lot of work within the System of Care strategic plan that is really about trying to fix this thing, the care coordination kind of problem, right? So it's very aligned with the longer term vision of the strategic plan. Feasibility, this would take a bit of a lift in terms of staffing. It would take policy changes, technology changes. That would take some funding. This would be kind of a long-term effort, but something that is something that I think we agree we need to do as it's directed in our strategic plan. There was also a suggestion around looking at what kind of training child psychiatrists get as it relates to coordinated and timely access to assessment and evaluation. So this work would, maybe tap into what already happens within licensing boards, medical schools, etc. I did follow up with Kyle Johnson, Dr. Johnson, who is the child psychiatrist on the System of Care Advisory Council, and he had some interesting things that to share that you can kind of read in the comments if you want. This would likely not be kind of a frontline intervention. There's just not that many child psychiatrists in Oregon, and usually you don't get to see a child psychiatrist until you've kind of been through a number of other providers. So, kind of question about kind of how much impact that would have, but it could be kind of an easy thing to pick up the ground here in terms of feasibility. I'll pause there. Anything else related to kind of that first topic of timely and coordinated access to assessment?
Christy Molly put a question in the chat about differentiating between the terms care coordination and case management. And I'm happy to kind of to do that maybe for this conversation, but also for like future conversations, right? And so other folks, if you see this differently, like this is not, now Anna says this is our operating definition, right? Like we can have a conversation about it. But in my head, when I'm thinking about care coordination, it is about having one central person who is sort of tracking what is happening in a person's case, who is aware of what is the current status. Are they on medication? Are they seeking an assessment? Are they trying to get eligibility for a particular program, right? Like one centralized person that is aware of all of the component parts of a young person's case and that is potentially making phone calls on behalf of that young person to get them access to the services that they've assessed as being eligible for, or following up on, hey, I submitted this referral, no one's heard back from you in 2 weeks, right? So that sort of active and intensive care coordination piece is really as a primary entity responsible for ensuring that the person is getting access to the supports and services, not just that they're aware that they're eligible for supports and services. And it's like, yes, I know that can also look like case management. However, case managers are often single system entities. So we have a DD case manager, we have a child welfare case manager. Those folks would be working with this care coordinator to make sure that the case they're managing in their single system is actually being managed appropriately, right? So it's sort of an umbrella over case managers to ensure that all of the different case components that are being managed via single systems are actually being coordinated by one person who's aware of the different case manager work. Maybe that's upside down. Some people, I think it the other way around. I'm okay to flip the terms and use them however makes sense in most people's heads, but that's sort of what we're thinking of when Christy and I are talking about case management versus care coordination. So I don't know if other people have reactions or responses or nuances to add to that.
Thank you. That's super helpful. And if everyone is in agreement that that's how we're going to use the terms, that's great. Appreciate it.
Anyone want to disagree or add nuance? Oh, I see more chat coming up. Yeah, that's exactly, Shayla's, what I was trying to describe.
I'm agreeing with you in there.
Excellent. Okay. And then Amy Fellows is asking, where will the care coordinators be housed? That is unknown. That is an answer that has not been determined by our full system as one system. Currently, they're housed all over the place and they have differing roles and differing responsibilities, and that's why this is a problem we would love to see one strategic answer to in the longer run. Shayla's?
I was going to suggest that right now, various case managers are also holding the role of care coordinators, depending on the need of the individual. I know a lot of our DD case managers pull various teams from different agencies together for that purpose, but I wouldn't call them care coordinators.
Yeah, I think that is true. And I think a lot of times it's whoever this young person's parent is really doing the care coordination work as best they possibly can within all of the, challenges that they're facing as a human being. Yeah, it does sound a bit like wraparound, Amy, and it could be using the wraparound model. That is a topic that has been bounced around multiple times. Trish.
So I'll just mention from my experience between the two, care coordination, DHS, the one worker I've had with DHS will do all the things, the referrals, the callbacks, all of everything. She will be the one person go-to for all the stuff. Case management wraparound is the one person that will set up the meetings, but it's a meeting with all the people and then everyone has their own little parts. So I think that you really touched on that really perfectly of like the difference between the two there is that the one person care coordination is that one person go-to, and then the case management has a team of people that kind of collaboratively work together.
Exactly. Thanks, Trish. That's really helpful. Okay, Christy, back to you.
Okay. All right, we'll keep moving on. The second category was improving behavioral health supports in schools, kind of what happens within the four walls of a school building. You all had 3 topics that came out of that. The first one was to investigate the standardized training, what kind of training teachers get, particularly around things like mental health, brain science, neurodevelopment, that kind of thing. This training already exists, and looking to my ODE colleagues to add in if I'm wrong here, but the Department of Education has a framework for transformative SEL, socio-emotional learning. Within that, there are standards that districts are supposed to be implementing. There are trainings that teachers and other staff can be taking. So this is already embedded in the standards, but the question here might be around the evaluation of these standards. So to what degree do schools and districts use these standards? To what degree are teachers actually taking the training? That kind of thing. And if my ODE colleagues have something more to share there, that would be great. Nate, I see you got a hand up.
I'm not an ODE colleague, but I also would just throw in there one thing I would be curious on is like essentially like the offering or implementation of those trainings from like elementary teachers compared to like secondary teachers for middle and high school. That from my experience, that tends to be where there's a pretty big difference. I would say primary educators tend to have a little bit more experience with this, given they're facilitating SEL in each of their classrooms. And then middle and high school, it's not, I wouldn't say that's as common.
Great.
And similar comment along the same lines in the chat from Anna Day about just teachers or aides and other support staff as well for this particular topic, Christy.
Yeah, great. Yeah, Alex got a hand up.
Yeah, I think this also goes back to a previous conversations about maybe unifying center of excellence trainings or so forth. But I think that comment that you made is the quality of what districts adopt could vary, but still meet those standards. And I think one particular example that child welfare honed in on a few years ago was the child abuse and mandatory reporting training. Some school districts are purchasing these trainings from national providers that had were talking about neglect, but they were also mentioning that a child having holes in their genes was a potential sign of neglect. So it was meeting standards, but it was also training staff to be biased and have these kind of institutional ideas that were not appropriate for mandatory reporting purposes. So I think that that material review or Oregon Health Authority has a list of trainings that have met certain standards or certification standards would be important. It's not the path, but it's really somebody looking at this training saying it's appropriate meeting our standards.
Great. Thanks, Alex.
And to clarify, child welfare now has a free mandatory reporting and neglect training that they offer to all school districts, to anybody who wants one, and that's how they resolve that.
That's what I came here to say.
Okay. So it looks like there's agreement here around kind of emphasizing the quality and like the implementation. Okay. All right. And then the next idea that came out of this second breakout room was the use of peers in schools. This is definitely something that we have heard repeated, especially from youth. There's a lot of evidence around the effectiveness of youth and peers. There's a lot of kind of models of how other states are bringing peers into schools. And we note that there are very persistent billing challenges in particular. So peers aren't currently included in providers allowed to bill Medicaid. There are some districts that have found other funds to bring peers into schools, but it is definitely not something that is universally acceptable or, in practice. So this to make this more, available to all districts and schools, it would probably require some rule changes. There'd be a fiscal impact. And there's a little bit more that I've been kind of exploring here with Medicaid, folks in the Medicaid division, but definitely still some opportunity to explore there. Okay, and then the last idea here was around ensuring readiness for kindergarten. Sorry, readiness twice there. A lot of work happening in this space. The CCO socio-emotional metric is getting at this. The Department of Early Learning Care Every Child Belong initiative just went online, I think, July 1st, and that has a lot of potential to improve this area. Excellent work happening within early intervention and early childhood special education, home visiting programs, a lot of programs that could be leveraged. So there's a lot happening here. I would love to hear from the committee exactly what value the System of Care Advisory Council could bring to these initiatives. What is like our unique role in terms of ensuring young people are ready for kindergarten. And also just to say that in terms of feasibility, that social determinants are a major driver here, and that is definitely out of scope for the council. Any other thoughts on kindergarten readiness, peers, or training that's being provided to teachers and staff? Remy.
Hey y'all, Remy Watts with ODE here. I am not sure how hard you want me to go off on this question, Christy. I can talk until the cows come home about this. I worked at Delk when it was still early learning division and helped the first phase of implementation on the Every Child Belongs Act. The couple of things that I think are important to note, and I'm not exactly sure, I don't know, you can muse about how SOCAC fits into it. But the way that the Every Child Belongs program is stood up is that we have the early learning hubs, right? But then there is a separate regional support entity that is stood up for the Every Child Belongs Act. And those can be early learning hubs, and they also don't have to be early learning hubs. So it's a little bit more confusing because you can't point directly to this is every single early learning hub is the regional support entity for early childhood big behaviors in every region, and I think that's an opportunity for local systems of care because the regional support entities are supposed to be the warm line where childcare providers who are supporting kids with big behaviors getting ready for kindergarten, that's where I think that it would be really crucial to connect with like early, not only the regional support entities, but also the early learning hubs, like every local system of care would be able to do those things. Ideally, they're already connected, but you know, I don't know what that actually looks like on the ground, especially because I'm not there anymore. So like that is an like opportunity point for the local systems of care, and then also like our larger state council. And then number two, regarding kindergarten readiness, there used to be something called the kindergarten assessment, but now it's called the early learning transition check-in. And it's essentially like a qualitative interview where kindergarten teachers are like talking to their new students and their families about the needs that they have, and you know, what it's going to be like for this kid to be in kindergarten. And I know that there are some social determinant of health questions in those interviews, and I need to check in with my colleagues on this, but I don't know exactly what happens after that interview happens, like the early learning transition check-in. And what happens if a kindergarten teacher notices some unmet like healthcare needs or some unmet special needs of this child coming into the K-12 system. So I think that that's another opportunity for SOCAC to explore. Those are the two things that I could think of immediately. And if you ever have any questions about that, I'm happy to talk about it more because I know a lot about it. Thank you.
Thanks, Remy. Anna?
I was just going to add about the Every Child Belongs. My agency in Lane County has been participating in that project. And one of the things that it has illuminated, it's geared towards supporting teachers and educational interventionists there. But when there is a need for behavioral health services for a little kiddo, there's incredibly poor access to be able to connect with 0 to 6 specialty services or dyadic treatment or things like that. So I just would raise that as a gap.
Great. Thanks, Anna.
So I just want to
Okay.
call out, there's an important conversation also happening in the chat around training mandates being unfunded, being really hard to implement effectively. That I think is just an important point to make sure we're sort of not just leaving in the chat, but sort of calling out into the conversation as well. I see your hand up, Alicia.
Hi. So one of the things I'm thinking about with that too is with Every Child Belongs, I was a part of the committee that gave feedback around the rules advisory committee for the Every Child Belongs or suspension and expulsion prevention. And I guess what my concern is that every childcare provider or preschool is required to come up with their own kind of system for support and need, and it's not really regulated. But I'm really trying to understand who is regulating and holding folks accountable for implementing their processes appropriately. And so, and to piggyback off of what someone else just said, because it's a consult model, I'm wondering about how much there aren't direct services for children, but also will they have the capacity to actually provide the level of consult support that is going to be needed? And so that's just a couple of things that came to mind when I look at this is when I think of kindergarten readiness for our kids with behavioral health challenges, I'm thinking of they're going to be getting early childhood support to understand what their needs would be as they transition into kindergarten. And I'm still concerned that we won't have the ability to really figure that out for kids as they're trying to prevent expulsion, suspension and expulsion. There's still, really no clear path to supporting them long term. So that's just my 2 cents.
Thanks, Alicia. Sheila?
Thank you. I agree with Alicia. I was also a part of the Every Child Belongs. And there were as a childcare provider, there were some issues whether the resources would be available. And because there had been before not available, and a lot of families were left in the cold. And as far as having the children ready to go into school and dealing with those issues, that is still happening. And so there is a gap, and they're not really sure where the money is going to come from for the providers. When I meant providers, I meant like the mental health providers and all that, because from my understanding, there's a shortage. So that is a big issue. And how is that? There really was no answer how that was going to be addressed, because there's also a lot of people who wasn't interested in going back into that field as well. So that was some of the things that was faced in that putting this program together.
Super interesting. Thanks, Sheila. That's really helpful. Kind of framing around what we could do or could not do. We're a little bit over time, Christy, but I wonder if you want to just kind of finish out the last couple things on this document. And then what I'm understanding, I'm hearing lots of feedback and lots of information provided. We are going to have to kind of distill it and come back to you at the next meeting with like, here's what we heard from you. Did we hear you right? Here's where we think we might be able to make some progress, kind of turnaround on this conversation. It's kind of all over the place with relation to this. So it's not, I don't know, Christy, just if you want to just finish the care coordination with community-based supports or coordination with community-based supports and see where we go from there.
Yep. Yep. Thank you for raising some of those other feasibility challenges though with that kindergarten readiness. It's really important context. Okay. And then the third category here was coordination with community-based supports, right? So how do we coordinate what's happening within schools with what's happening outside of schools? And you had three things that came out of that discussion. One was related to FERPA and HIPAA, the Family Educational Rights and Privacy Act, and then HIPAA, Health Insurance Portability and Accountability Act, and how those things interact with each other in ways that often creates barriers for people trying to serve kids in schools. It sounds like ODE is already kind of working on this, or this is on their radar. There are some really nice examples of resources that other states have put out to help schools and providers understand these rules. California has a really nice website as one example. The Oregon, I think it's the School-Based Health National Alliance, has put out some sample MOUs or kind of documents that communities can adopt to really kind of like streamline and make everybody feel better about the information that they're exchanging. So there could be some relatively easy fixes here in terms of education, information, and training about these laws and really clarifying what you can and cannot share. And at the same time, these are both federal policies, and requires kind of legal guidance to interpret those federal policies. So training and education could be highly feasible and have a lot of impact. Okay, the second idea that came out of that group was to improve provider literacy about how other systems are functioning. Again, some examples of this already exist. The Tri-County System of Care on their website actually hosts a series of like 101 presentations about the various systems on their website. Like it's kind of a pretty cool, hour-long presentation. And then you can go and you can kind of learn about like, well, what is the behavioral health system, or what are the services that the IDD system offers, that kind of thing. So again, staffing and resources would be required to assess the available trainings and gaps, developing curriculum. We are exploring a potential contract with the System of Care Institute to develop some training modules, mostly for local system of care coordinators, but this could be kind of part of the package and the suite that we put together. And then the final topic, again, there was this care coordination topic that also came out of this third group. And we've already explored that in more depth. So unless there's anything else to say here, Anna, I don't know. Do we want to talk about the care coordination work group a little bit more deeply, or take questions?
I mean, that is the next topic on the agenda, but if you just want to pull down so that's sort of, Christy has been sort of steering this work. A lot of people have contributed to, okay, what are we going to do for our sort of low acuity priority? This is sort of, we've had a focus group, we've done some listening sessions. these are sort of the options that were gelling out of those conversations and the conversation that we had in here last time. So I don't know if you all are feeling like there's an answer on that grid that like this is the thing we want to pick for our low acuity priority. If there is, please like go ahead and tell us what that is. I did not get that vibe from this conversation, but I got a that's important and this is important and that is important. And so I'm not sure that it's clear where we're landing now. Leah, as chair, I don't know if you're feeling a different like something gelling in your head that you're like, Anna, you're just missing it. Do feel free to name that.
No, sorry, I was reading while you were talking, and so I missed some of what you just said. I apologize.
Oh, that's okay.
But
Just trying to figure out if we sort of just say we're going to let this simmer for a minute and come back with some low acuity, another low, like we need to make a decision, right, about what our strategy is going to be to address access to services and supports in schools. And this was part of that conversation, but it isn't driving us towards here's the answer. That this is the project we want to assign to ourselves for how do we make some progress around improving access to services and supports in schools. And I also want to acknowledge your comment about diagnosis in the chat. If you do have access to that PDF, which is available on our website, there's an interesting, the pink part of that document, the comments from Dr. Kyle Johnson connects to some of that comment that you made in the chat. Yeah, so I don't know. I think we need to spend a little more time thinking, Christy, unless you want to. I personally think working on HIPAA and FERPA makes the most sense because it's the like lowest like we can't change those policies, but we can dramatically improve understanding of those policies. And I think they're often over applied and over interpreted because people are fearful of liability around them. I know that creates anxiety for Remy Watts right now. But in terms of like what could we do that could have impact that is not going to be expensive in the budget environment that we are entering into, where everything is going to be like, oh, that costs money, you're not allowed to do it. It feels like a doable project. So that's my recommendation, and full transparency, it's my recommendation because it's the thing I think we can do mostly for free that would have any impact at all. Nate.
I would love that to be a priority. That is one of the number one things that we've heard from folks in my region regarding like getting like county mental health support within school settings. They manage it, but a lot of it, what it comes down to is that FERPA, HIPAA clash there, or perceived clash. So I think that would be incredibly helpful.
Thanks, Nate. That's really helpful comment.
So Anna, are you then thinking about like tabling the committee work group piece?
No, so that's those are two different things, right?
Okay,
So this
just
is
wanna
the
make
low
sure.
acuity. So what we're sort of moving towards is another, probably a charter around the low acuity project, and then we're gonna pause the low acuity conversation in a minute and move to the high acuity conversation. That's what the work group is, right? And so we'll do another similar round of this for school-based services and supports. Does that make sense? Am I confusing people? I feel like I'm not facilitating effectively. I apologize.
No, I think that was good. Cleared it.
Okay. Okay, so I personally am leaning towards HIPAA FERPA. Nate is leaning toward HIPAA FERPA. Does anybody disagree that we might come up with a draft proposal to bring back here for feedback? And Remy, if you disagree, you are welcome to speak up, friend.
No, I absolutely do not disagree. I think that one of the powers of SOCAC is being able to work with community partners to help them understand how to work with schools the best. And from my perspective, I can help schools understand how to work with community partners in the best way. And I know that we've tried to do that at ODE before, but I am pushing my analysts that we're going to do it again and we're going to do it differently. And I don't care how many times we've done it before, we've got to do it again because we haven't gotten it right yet. And yeah, I am all for this conversation because it personally annoys me greatly. So thank you.
Excellent. Okay, so we'll draft up a proposal around how this committee might choose to engage around HIPAA FERPA, and then you all will get it in your email. We'll discuss it at an upcoming meeting, and we'll refine it and build on it and get it to a place where people feel like this is a good thing for us to do, or we won't do it.
Yes. And Remy and Molly, I would love to work with you on that a little bit. Okay.
Making sure we're getting the language in terms that ODE and OHA can feel comfortable moving forward with. And we'll bring this to the FAC as well, so that we have our family leaders' perspective infused in the draft.
Is there anybody here today from Child and Family Behavioral Health? They should be looped in. And then
Hillary's here.
I'm here,
Oh,
and I
Hillary.
think
Hi,
Chelsea's
Hillary.
here. Hi.
Okay, great.
And in the chat, someone's saying that Fran Pearson, who was here last month, she's unfortunately not here today, is working on some of this clash in her school-based mental health partnerships learning collaborative. So I think there's already some work to put in a bucket.
Perfect. And Nate mentioned that in the chat as well. So I love this like alignment. Excellent.
Yeah,
We'll make
and
sure
we
that we're looping
may
that
want
in.
to pull in folks from PhD to on the school-based health center element as well. So
Gotcha. Okay, Christy,
I'm
that's
happy to
really
help with any of
helpful
that.
drafting information for you. Excellent. Okay. Leah, is it you or me who's introducing the next topic? Me. Okay. So, we taking a pause on the school-based stuff. The other task that this committee was assigned was choose a priority around high acuity interventions for kids with complex needs. High acuity means kids who are at risk of or in need of a residential placement or removal from their current environment, including juvenile legal involvement, temporary lodging, hospital, ER boarding, those kinds of things, right? The things that we hope to avoid for every youth. Unless they need hospital level care, then we want them to get it. And so we have talked about this topic a few different times in a couple different ways. We took all of that feedback and recommendations, and the choice that this committee made to prioritize something around care coordination. We drafted a charter and then did our equity review on that charter. And Christy, if you will flash up the charter, you all should have this in your inbox. You do not have the equity review, but we'll review that as well. And then we'll make sure that it's posted online for review. And then there's a couple sections that we'll need to fill out after we've had a quick conversation about it.
Anna, the one that's in the calendar appointment wouldn't have the changes I made.
It doesn't have the equity
Okay,
changes to it. That's
but-
why I'm wondering if you can share the new
Oh,
one,
the
or
newer
you
one.
made the updates to it after the equity process was applied.
Let's hold.
Do you need me to pull it up?
I got it. Okay. Right.
So for some of our newer members, you have not seen this form before. For those of you who have been with us since we reconvened this committee at the beginning of 2026, this is the charter, the template that we use for drafting work groups and committees that say, like, what is the purpose of this? Who's going to be involved? What are we going to create? And so this is a proposal for an integrated care coordination work group that would be chaired or sponsored by a member of this committee and a member of the council. Those can be the same person or two different people. We need one governor appointed member to sort of take responsibility here, and we can figure out who that is. But the purpose of this work group would be to determine what care coordination should look like, who will hold that, right? A lot of those questions that were coming up in the chat about, like, what do we mean when we say the word? Who does it? Who's ultimately responsible for it? How do we pay for it? How do we make sure that we're holding each other accountable for it? And so a lot of those questions are unanswered. That's what this work group would be intended to answer, create recommendations for answering. And so they would map out existing care coordination programs. They would synthesize existing care coordination experiences, what's happening in wraparound that's working, what's happening in other care coordination experiences that are working, what's not working, what are strategies that people are using that are not effective that we should sort of rule out of our recommendations. They would review literature on care coordination, models that are, again, working in other states, particularly ones that are relevant in context to our state, recommendations made in past policy documents in Oregon. and then develop specific recommendations for what integrated care coordination across systems should look like in Oregon, including do we use universal screening or assessment tools? Do we use particular technology platforms, or do we look for technologies that can perform specific functions? What are those specific functions? Workforce considerations, eligibility criteria, consent and release of information protocols, culturally and linguistic responsiveness, and any kinds of required resources, which a lot of those things that I just named are required resources, but anything else not listed there. And then this work group would work with the data and evaluation committee to identify performance indicators. So we could say that we know what we're at for baseline, we know where we're trying to go and how we're going to measure it. And also to work with the investment and finance committee to identify specific funding mechanisms to ensure that their work is actually resourced appropriately. We propose the committee should meet virtually for 1 hour a month. The committee members would decide the date and time once they are identified. They would follow our bylaws because they would be organized through us and use our equity tool before finalizing any decisions. And then to Leah's question in the chat, yeah, we did identify that we forgot to add a lived experience. Like, of course, lived experience would be there. We did not list it when we put it there. We apologize for that. But as we did the equity process, we were like, oh, right, got to make sure lived experience is at this table, right? So, Christy, if you could scroll down to who we have: family members with lived experience, youth with lived experience, people who have wraparound experience, people who do care coordination through the CCOs or oversee it through OHA, people who do fee-for-service care coordination, which is actually different and not governed by the same rule set that CCO care coordination is, certified community behavioral health clinics or CCBHCs, county mental health programs or CMHPs, child welfare case managers, ODDS case managers or CDDP, community developmental disability case managers, parole and probation, home visiting, specific people from special ed, private insurance, if they do have care coordination. I know Kaiser does. Somebody from the courts, juvenile courts, and then culturally specific providers. So these are the folks that we would recruit to this. First of all, are we missing folks on this list that have a relevant and important perspective that should be invited to this table for this conversation?
Trish, see your hand up.
Sorry, I do see it there. I thought I was missing.
Great.
Okay. So it looks like
sorry, is there
No, go.
anyone from the early education or early childhood settings? I'm just thinking about relief nurseries and so on. You've got home visiting, but there's then a gap through until kindergarten that you've got. If you bring in home visiting, there are folks who are with some of those programs that end up doing some limited case management. I don't know. I'm just wondering how loose you want to be, because home visiting and case management, I'm not sure whether I would put them in that bucket, but if you're including them, I just didn't want to miss the 3 to 5 year olds.
Gotcha, Hillary. So Christy, you had thought home visiting, and I understand what Hillary's saying. Like, if we're doing the like post-birth home visiting and then we're not doing anything until school, we've got an age gap there. Is there an intention behind that, or is it just
No intention, but maybe what we could do here is specify that this is both like K through 12 education and early intervention, early childhood special education, or maybe you're talking more about like early learning hubs, Hillary?
I am talking more about early learning. I'm thinking, relief nursery, that kind of thing. But I'm not clear how much case management happens there. There is some.
Yeah, I don't know, actually.
There's also some that happens because of court that in that space between being DHS involved and not DHS involved for relief nursery, where they're case managing to keep people out of that space.
I would actually think case relief nurseries would be a really interesting one, Christy, and maybe we have them on that same sort of line of early learning hubs slash release nurseries. I think we need to do some research out to them and find out, are they doing case management or care coordination in any way? And then if they're not, probably they don't have anything relevant to bring to this table. Trish, is that an old hand or do you have something else to add?
Yeah, I have two other. I don't know if there's one of them I'm unsure if it fits in any category that's on here. Community-based services, so like POIC or NAPI could be two, like some of those kind of community-based services that help. They're not really mentors or case management, but they offer different kind of services that help with students and kids. And then also we don't have like probation or parole, but we do work with detectives. So whatever category that could be as well.
Okay, and you said POIC. I didn't understand the second entity that you named.
NAFI is New Avenues for Youth.
Gotcha. New Avenues for Youth. Gotcha. Okay. So POIC
Just like
POIC.
community-based services. There's multiple, but those are the two that we utilize.
And then Anna also mentioned outpatient mental health providers, mental health treatment providers.
Yeah.
Christy. So I'm just putting those in the chat so that we kind of have a record of them. Okay. And then briefly, Christy, if you could bring up the equity tool. Or I can bring it up since you're still taking notes here.
Yeah, I can bring it up. But Trish, going back to your point, you talked about like detectives. Like that makes me think like law enforcement kind of folks. And I don't, it's interesting. We don't really talk about law enforcement. It doesn't really come up. We focus really more on like juvenile settings. So I don't know. Sonia, I guess, what do you like? Do the police have like a case management type of role that work with
No.
No.
I mean, they interface, of course, with all of these organizations, but there's no case management or coordination of care. It's usually the one-time contact and then they're out.
Yeah. They hand them off to you and then they're kind of out, right? Okay.
And I think the ongoing work is in that probation and parole space. Trish, I don't know if that makes sense or clicks in your lived experience. Like that is how from the system side it's supposed to work. How does it actually work could be different. Okay. Okay.
I'm sorry. I took a call in between that for the question with the the detective part there. Did I miss something with that?
Oh, because you had mentioned detectives and then Christy was like, do law enforcement or detectives have case management roles? And Sonia said, not really. I said, I think that case management lives more on the juvenile probation parole space. And then I just wanted to say, like, I know from a systems perspective, that's how it's supposed to work. You have a lived experience that may not be how it actually looks on the ground. So I just was like checking that against sort of your grassroots experience of like, I'm way over here. That's how it's supposed to be. Is that how it plays out on the ground? I don't know.
Yeah, with our experience, like they don't do management, but they definitely have a voice and they will offer assistance with our case management. So they've jumped in with wraparound meetings and offered other kind of resources and stuff for their own options that aren't with other sources that we have. They have their own type of resources they can offer. They take other calls and they have other information that we don't have access to. So they've been helpful in other avenues, if that helps at all.
Yeah, it totally does. Okay. And then Monique is mentioning kids with complex needs like residential treatment or hospital settings. And Sonia is talking also residential programs or day treatment. So somebody in that higher acuity treatment or facility space, Christy, as well. Okay, so and then this is so we'll add that in, these recommendations that have been coming in the chat. And then this is the equity tool that we ran on this proposal. So the summary of the proposal is the proposal is to form an interagency care coordination work group, which is a subset of the program and policy committee for, the intent is that we decide this today, or at least discuss deciding this today. Is this aligned with our mission and values? Yes, it is aligned with our mission and values. It would center youth and family experience in understanding the current day-to-day operations of what care coordination looks like. Recommendations will detail opportunities to improve care coordination through sustainable system change, which is our deep value, while ensuring systems are accessible, particularly to those who are marginalized due to race, gender, ethnicity, sexual orientation, disability, and geographic location. Christy, I would add there, and like intersections of care, right? So disability, geographic location, and like complexity of care needs or something, right? I think one thing that we often see people disqualified for services is that they're just like too complicated to serve. So who is driving this project? That is us. Our strategic plan is driving this project. In that we were told ourselves to prioritize something in the high acuity space, and this is where the sort of all of the conversations have been. One dominant theme has been really leading to, well, care coordination is the big barrier. Christy wrote that in institutional language. Who is most impacted by this proposal? So rural communities, youth involved with child welfare, youth with disabilities, and youth involved in the juvenile justice system, and particularly youth who have more than one of those particular identities. And then how did we engage with the community? So this has been an ongoing theme. Came from our focus groups, and there's a whole bunch of links in answer number 5 regarding the sort of data and policy driven reports that also identify care coordination being a giant gap. And the members of our Family Affinity Advisory Committee and our Youth Affinity Space have identified that care coordination is a deeply frustrating experience for them when it doesn't work out well, and will continue to be included and consulted as we create and craft the recommendations in this work group. We've heard no one opposes the idea of improving care coordination. Lots of people have reasons why it will be hard. Particularly in the context that we are entering into, where our service system is likely to shrink based on billions of dollars of federal funds being taken away from Oregon and millions of rural health transformation dollars supposedly replacing that money. Here are some of those links that Christy referred to. And, the one caveat is that it may be difficult to plan in an environment where our service environment is contracting at the same time we're asking for something to be built. The intention of this work group is to have a positive impact on marginalized communities. So our commitment to racial equity is to focus on people who have been excluded from services and supports based on their racial, linguistic, or cultural identities, particularly in our settings. Black and Native kids and those who speak Spanish at home are the ones who are least likely to have access to this, or whose parents speak Spanish. Are the ones who are least likely to have access to the services and supports that actually work for them to thrive at home in their schools or in their communities. And so we will intentionally prioritize focusing on those groups and what they need from a process of universal design. If we can build care coordination that works for intentionally marginalized populations, it will work for not intentionally marginalized populations as well. I don't know if there's more to say on that one, Christy. Okay. So, do you all think that we should charter a work group? With the additions and changes that you all made in this conversation, would you like to see the draft again and vote on it at the next meeting? Would you like to vote on it in this meeting? Would you like to say this was dumb and we should do something different? How would you like to respond to what Christy and I just said so many words of in front of you? Well, don't everybody talk at once. I can't hear you when you're all talking over each other.
I think we should vote on it at the next meeting once we all have a chance to get a clean version with the recommended, with whatever recommended people you add.
Okay. So Leah's proposal is we make the changes that were recommended in conversation today and bring it back for a vote at the August meeting. And Courtney Esparza gives that a thumbs up. Anybody wish to? Remy Watts gives that a thumbs up. Sheila gives that a thumbs up. Nate gives it a thumbs up. Well, somebody gave it an exploding thumbs up. All right, that's what we'll do, friends. We will bring this back to you. We'll get it out to you in advance so you can read it. And Trish, I'm not sure about the accessibility standards. We don't have all of our stuff in templates that are actually accessible right now. We accidentally got left out of the OHA accessibility process. They forgot we existed. And so we're working on getting that cleaned up. Our communications director starts on Monday, and he will help with that. But no, we are not there yet, and I apologize for that. But we will clean it up in the existing format and work to get it to accessibility within the year. And if you need specific support, Trish, do please reach out if there's like a way we can make it better for you. We're happy to adjust, or for whoever you're working with, if it's making it accessible for others. Okay. So then we are done with the high acuity portion. Miss Leah, I think it's you again.
Yeah, and we've actually gone over our time, so I'm going to make this shorter so that we have time for the other pieces.
Fair.
Sorry, Anna. So now we have, I don't do math well. I'm going to go with 15-ish, 20-ish minutes to talk about SOCAC's legislative report, which is due to be submitted by September 15th. And that should say 2026, Anna. Anna's going to explain the process and timeline for that, and Cody Welty here to explain the data side of this report. So you guys get to battle it out on who wants to start. Ready, go.
Cody, you go first and you go fast, okay?
Not a problem. Just gonna make sure I can share. I will be speedy. Okay, can you all see this Word document? Any
Yeah,
thumbs
but
up?
if you could bigify it a little bit, it's like too small to read very well.
Okay.
That works for my eyeballs.
The purpose of this measures update report, I want to set context here so that people don't look for incredibly detailed data. That is not what the purpose of this. This is not a data report. This is an update to the measures that were included in the SOCAC strategic plan. It's meant to be broad because our measures are broad. So you won't see crosstabs, you won't see these really detailed explanations of what everything means. There are other places for that that we have. These are simply, how have the numbers changed since our strategic plan, or was there any update that needed to happen to the measures? It will be in this format for every single strategic plan measure that we have, from our baseline to the current year. What was the percentage change from X year to X year? And what does that mean? I'm going to scroll fairly quickly so you can see how this is looking. This is not the entire report. This will be used to inform the legislative update on how we're doing as a council with our measures. Some of these aren't able to be updated because the data don't exist yet. So for example, we don't have graduation data yet for the 2025-2026 school year. Education is working on those. We expect those in November, but it's not really feasible to get an update on those yet. This is the format that it's going to be going out in. Anna, I will pass it to you. I hope that was quick enough.
That was very quick. So the System of Care Advisory Council is required to submit a report on September 15th of every year about, and it has some very specific reporting requirements in it. One of those is, quote, how the council is meeting its goals. So what Cody was just showing you was how we're going to report on how we're meeting our goals. Our goals are the goals of the system at large based on our strategic plan. So if you look at our strategic plan or these little posters that we have of them, it's on the results and outcomes. It's increasing the percent of youth reporting they have a safe place or person they can go to outside of school, decreasing the percentage of youth reporting an unmet mental health care need. decreasing the percentage of youth with substance use disorder, right? These are system level metrics that if the council is meeting its goals, we're seeing improvement in those measures, right? Things are actually getting better for kids on the ground. Things are actually getting better for families on the ground. And we can measure those improvements based on these measures that we have. So that is what Cody is doing right now, is taking the measures that we've already agreed to and just updating. So here's what it was when we created the strategic plan. Here's where it's at now. Is it going the direction we want it to or not? Or can we not tell? That is one piece of what we are doing for the required legislative report. The other, so here's what the mandate says. The council submits a report by September 15th of each year describing how the council is meeting its goals, the remaining barriers to access to services and supports, and recommendations for legislation. So how we are meeting our goals is what Cody just showed you, and how we're updating that. In terms of, I'll paste that language in the chat so that those of you who are visual prioritizers can see it as well. In terms of remaining barriers to access to services and supports, we could write a book about it every year. But what we will do is, again, use our strategic plan with the priorities that we set in there around school-based services and supports, increasing access to school-based services and supports, decreasing temporary lodging and emergency room boarding, increasing access to community-based care, and increasing accessibility and equity and affordability. I'm going to draft some specific, these are things that have happened that are making improvements. If you are paying lots of attention to our strategic planning nerdery, there's an implementation plan tracker. And so I will talk about how many of the 2026 goals are in process, how many of the 26 goals are completed for our strategic plan. That draft will come to you all at our August meeting. So our August meeting will basically be following up on this vote that we need to make on our high acuity, following up on our school-based services conversation, and reviewing and making any amendments to the legislative report. Then that report will go to the full council for final approval and submission on September 15th. So you'll get some homework, I guess, in your email. Those of you who have the time to read and prepare, great. Make recommendations via email, you're very welcome to. Those of you who want to make recommendations at the next meeting in person, we will be accepting them there. And then we'll send that back out to everybody to say, here's what we got. Did we get it right? You'll have a chance to follow up with me by email. One thing to be aware of, we can't have Anna and Courtney and Sonia emailing each other, because that falls in violation of the serial communications rule for public meetings. So I have to be your point of contact for that as your staff. But you all can email me your recommendations, and I can say, here's how I integrated your recommendation into the draft, and send it back to you with it highlighted or whatever. That's how we kind of have to do it, like Spoken Hub. Questions, comments, or things you want to make sure are considered as we are drafting this report beyond what we've already shared with you? And I don't think we are including recommendations for legislation in this report unless you all tell me what you want to see recommended for legislation, because I do not see a whole lot of proactive system building legislation happening the year that all of us are really focusing on the budget cuts that we're facing. We're more trying to figure out how to, and maybe we talk about protecting children's services through the course of budget cuts, right? And that's the recommendation we have for legislation, is making sure kids don't get all their services and supports cut as we're trying to figure out how to balance the budget.
And we had a comment from Anna Day in the chat about adding to the report whether it shows if a change is in the desired direction or not. And I said I would be happy to include that. So I just want to make sure that was in the vocal record.
We will do that. Okay, well, if there aren't any suggestions at this time, do feel free to reach out and send me those if they pop into your head via email. And again, you'll get the draft report in your inbox to review before our next meeting. So you'll also have an opportunity at that point to make recommendations when you have it kind of in front of your eyeballs, like, oh, you missed this thing. Okay. Then we're actually ahead of schedule now. We're opening up for public comment. Are there members of the public, non-voting members in this space who just have stuff to tell us? All right, that was long enough. I'm not hearing anyone. If you do have a comment you'd like to make, but you don't feel comfortable speaking it out loud, please feel free to put it in the chat. We can read it out loud for you. Or you can chat it to somebody in this room who feels like a safe person and they can read it out loud for you. Unfortunately, right now, I do not see any of our peer support providers in the room. I could tell you the vast majority of humans in this room will be happy to read your comment out anonymously. Okay. Well then, is there anything from the committee members, things that we didn't spend enough time talking about you want to go back to on the agenda? You have a thing you still want to say? I know there was a really active chat conversation going on that I did not get a chance to read all of. We will paste it. So we post these videos on YouTube and we do paste the full chat log in the comments on YouTube so that folks can see those chats as well and all the rich information that is shared there. Darian.
We cannot hear you, Darian.
Yeah, I don't know why we can't hear you.
You're not on mute. We just can't hear you. I did notice that you posted.
Oh no.
Oh, there you are.
Oh, there we go. We got you.
No, just kidding.
Can you hear me
she's
now?
frozen. Yep.
Family Support Network. There is some support groups and trainings on our website. There's also a really great one starting in August called Fatherhood Unfiltered. So go check those out. Sorry, my network is not great.
Thanks, Darian. We appreciate it. And she put the link in the chat for the support groups as well. Darian, if you want to turn your camera off, maybe we'd be able to hear you better.
Yeah, I'm so sorry. I popped it in the chat. My connection's not great, but these are some upcoming support groups. The Fatherhood Unfiltered is happening in August, so go check those out.
Thank you so much, and really appreciate the energy and effort to engage fathers. I will be going to a Fathers Advisory Committee meeting on Friday that is hosted by the Child Welfare team and try to really engage more dads in this leadership and activist advocate work that so many of you are already involved in. So hoping to invite some dads to the fact. I know there's a few dads that do participate, but looking to get more dad participation wherever possible. And then we do request, if you can, take a few minutes since you have a schedule till 4:30 to complete the meeting feedback survey. This meeting feedback allows us to ensure that folks are feeling heard, or if they're not, we know and we can adjust our strategies. And also allows us to track progress towards our strategic plan on sort of how we're doing what we're doing. If we're doing things differently, things should be starting to change. So please take the time to fill out this brief survey. It really does help us. And does anyone else have anything to say for the good of the order before we wrap up?
Only that our next meeting is August 26th.
Thanks.
From 3 to 4:30 via Zoom.
Via Zoom. See you here and probably somewhere in between. Take care, everyone. Appreciate you.